My name is Usman Said. I'm a consultant ophthalmologist at the Royal Liverpool University Hospital and an honorary clinical lecturer at the University of Liverpool. This lecture is basically aimed at uh, nurses who are undergoing training for their requirement for an MSc in ophthalmology. We're going to talk about the role of ocular coherence tomography, or OCT, in ophthalmology. Conventional retinal imaging basically sees the eye as a front-on image. I've shown you a picture of my eye with a conventional retinal camera. You can see the conventional retinal camera on the top right image over here. There are newer methods of imaging of the eye, and my eye is depicted on the lower right picture with an ultra-wide view imaging system called Optos or Optomap. The OCT is a technique for obtaining images of translucent or opaque materials, and it's a non-invasive method, which means that we're not doing anything to change the patient. It's literally as simple as taking a picture of somebody. An ocular coherent tomography, or an OCT, doesn't involve any radiation, and it therefore does not cause harm to the eye. The OCT can give us information about macular thickness and presence or absence of macular edema. It can give us assessment of the optic disc, which is very useful in glaucoma. The retinal pigment epithelial layer can be assessed, and they can be assessment of dry macular degeneration and progression, wet macular degeneration and progression, and assessment of treatments with wet macular degeneration. Anterior segment OCTs and iridocorneal angle OCTs can be obtained to give information about the status of the cornea and the status of the iridocorneal angle, which is quite useful in glaucoma. Apart from the uses in ophthalmology, there are a lot of uses in the general industry regarding OCTs. Basically, the principle is indirect interferometry, in which a beam of light is directed onto the retina. The resulting backscattered light travels in an unknown distance to a detector, which is then compared to a reference beam of known length to calculate the echo time of light. There are different types of OCTs. The initial generation, or the first generation of OCTs, had time domain OCTs, which the reference arm mechanically moved and the echo time delayed were measured one at a time. The acquisition speed of OCT devices was about 400 scans per second, and therefore the resolution was quite low, with quite a lot of granularity appearing in the scans. The second generation came as spectral domain OCTs, which had a fixed reference arm to generate an interference pattern, and therefore the image acquisition speeds were much higher, about 18,000 to 50,000 A scans per second. It gave a much better resolution of the retina, and the resolution was 3 to 7 micrometers. The newer types of OCT are swept source OCT, in which there's greater penetration with good view of the choroidal vasculature. The spectrum is either filtered or generated in single successive frequency types and then reconstructed. Basically, these give very high resolution with good visualization of retinal structures, as well as choroidal structures as well. And this helps in choroidal visualization as well. The latest systems are SLO or confocal systems like Heidelberg. It uses laser interferometry, and the resolution is much higher, to around 3 microns. The penetration might be compromised in earlier systems, but in the latest SLO systems with Heidelberg, the view and the penetration is really good, and you can have good views of all the retinal layers as well as significant visualization of the choroidal layers, which is really helpful in cases of measurement of choroidal thickness. They are wider field OCTs, and they can take images of the retina and a wider field OCT, which means instead of having a 3 mm or 4 mm cube of the macula being scanned in the center of the eye, larger areas of the retina can be scanned at one go with up to 12 mm areas of the choroid and the retina being scanned at the same time. Depending on where you are, you might encounter different types of OCTs. They could be Zeiss Cirrus 500, a Topcon Atlantis, a Heidelberg OCT. They are OCTs that combine a retinal picture and an OCT scan. Examples like Zeiss Photo 600 or a Topcon FA 2000. There are other capabilities in certain machines as well, which can take a retinal photograph and an OCT and an FFA capability and an ICG capability. And examples of those would be Heidelberg OCT machines. There's also Zeiss Cirrus 800, which can do retinal photograph, an OCT, and an FFA. There is also Topcon Triton FA Plus, which will do a retinal photo and an OCT and an FFA. It really depends on which setting you are in, which hospital you're in, and the departmental preference, but they all basically work in a similar fashion to help the clinician in the diagnosis of the patient. And basically, these are images showing different types of OCT scans, and depends on which department you're in and what the space requirements are in your hospital. Image quality is usually very good in the modern fourth generation OCTs. Prior modalities like time domain and Fourier domain OCTs have now been superseded almost everywhere by the newer methods. Generally, the swept source OCT has deeper choroid penetration, and Heidelberg OCTs generally tend to have the best image quality, along with capabilities of doing an FA as well as ICG and OCTAs as well. In certain types of OCTs, an anterior segment OCT can be done, and this will help for measuring the corneal thickness. The lower picture over here in the lower left shows a corneal OCT of a patient who's had LASIK, and the interface of the corneal LASIK procedure can be easily identified. The first image on the top left is the image of an iridocorneal angle, which shows the drainage angle of the aqueous humor, and this may be quite useful in patients who have glaucoma, and to determine which type of glaucoma they have, i.e. is the angle open or is the angle closed. Glaucoma assessment is another parameter which can be identified, and the cup disc ratio, disc size, retinal nerve fiber layer thickness, cup disc ratio, and retinal nerve fiber layer quadrant thickness can be identified. OCT scan of the macula is employed quite frequently to diagnose wet macular degeneration, as well as the effect of treatment from anti-VEGF injections. The presence or absence of macular edema generally shows if the treatment is working or not working. And as anti-VEGF treatment continues over the course of months, the OCT scan will show whether there's a recurrence of fluid and recurrence of macular edema or not. Wet macular degeneration can present in various formats. It can present as pigment epithelial detachment. The top right image shows pigment epithelial detachment with fluid present in the subretinal space. The macular OCT can also show advanced wet macular degeneration with fibrosis and scarring, as well as end-stage macular disease. A macular OCT scan is also very helpful in identifying dry macular degeneration, measuring dry macular degeneration, and more importantly, excluding wet macular degeneration. Progression of dry macular degeneration can be performed. In certain types of scans and OCT scans, especially swept source OCTs, the OCT obtained can be of fairly good quality even if there are significant media opacities like cataracts. In other types of OCT scanners, the image quality is significantly degraded if there are a significant amount of cataracts. The example is the image on the left, which shows a fairly good quality OCT scan, and the image on the right, which is the same patient and which has developed a cataract within 6 months, and the vision has dropped to counting fingers with a significant cataract. You can see the image quality is fairly degraded, and the retinal layers can hardly be discerned. Diabetic retinopathy, especially diabetic maculopathy, is a concern, and diabetic maculopathy can be quantified in terms of the macular edema with the OCT scans. This is important as in many centers and in many healthcare systems, the anti-VEGF agents and anti-VEGF medications are rationed. In the UK, the threshold for treating a patient with diabetic macular edema is 400 microns of macular edema in the central foveal area. Anything below that level is not NICE funded. And in this slide, we can see a patient with diabetic macular edema, and the image on the left shows very significant diabetic macular edema, and the image on the right shows the effect after treatment with significant improvement in diabetic macular edema and hopefully improved vision as well. We're currently using OCTs for virtual clinics, especially for diabetic maculopathy. These are instances where patients come, have an assessment with the nurse regarding their visual acuity, intraocular pressure, have a dilated retinal imaging with an OCT and an Optos camera, and then the patient leaves without seeing the doctor. The doctor will then subsequently view the images, including the Optos scans, as well as the OCT images, and then write to the patient. This type of clinic is particularly liked by the patients because they can see what's happened and they can get in and out of the clinic very quickly. In certain patients, diabetic retinopathy and diabetic maculopathy can be guided by having an OCT, and patients who are about to undergo laser treatment sometimes would benefit from having an OCT scan. Diabetic macular edema needs to be quantified, and if there is significant diabetic macular edema which is within the central 1 millimeter of the fovea, this can be identified with an OCT machine, and a central macular edema would likely sway the treating surgeon's decision towards anti-VEGF agents. But if the central fovea or the macula is not involved, then another treatment option called macular laser might also come into play, and this decision would be greatly helped with an OCT. Hence, most clinicians ask for an OCT scan. In our VR clinics, a lot of patients do come with diseases like macular holes, and OCT scans can help identify different types of OCTs and different types of macular holes, whether they're lamellar macular holes, whether there are full thickness macular holes or partial thickness macular holes. OCT scan can also help predict the prognosis with the area of gap between the retinal layers being more or less corresponding directly to the amount of vision that may be retrieved after surgery. And this is a scan of a patient who had a macular hole, and the image on the left shows a macular hole before surgery, and the image on the right shows the status of the macula after the macular hole surgery. You'll notice that there is absolute no vitreous echoes in the image on the right, whereas some vitreous echoes can be seen on the image on the left. Vitreomacular traction is another entity which can be identified on modern OCT scans. This basically means that the jelly of the eye is pulling on the retina at the back of the eye and disturbing the structure of the retina. Vitreomacular traction could be a candidate for jet-RIA if symptomatic, but the success rate is fairly low. And in our unit and most other units, vitreoretinal surgeons would much prefer doing a vitrectomy if the vitreomacular traction is significant. Epiretinal membranes can be identified clinically as well as on the OCT scan. Epiretinal membranes such as these can be identified on the OCT as well as clinical examination, and they can lead to distortion. Usually after the surgery, the distortion is much more less, and the patient's vision quality improves significantly. Another issue where OCT scan is very helpful will be retinal vein occlusions, where it's very important to find out whether the patient has macular edema or not. If the patient does have macular edema, the patient can be offered treatments like Avastin, Lucentis, Eylea, Vabysmo, or steroid agents like Ozurdex implant. In patients with retinal vein occlusion and a macular edema, usually a fluorescein angiogram is done, and an OCT can provide some degree of idea about the prognosis. This should give you some more idea of the importance of OCT scans and why, as doctors and ophthalmologists, we order OCTs for a lot of our patients. These do help in a number of eye conditions, and because of these, prognostication, diagnosis, and treatment is helped quite significantly. Thank you very much. If there are any questions, you can send me an email, or you can contact me at the Royal Liverpool University Hospital.